they're declining of listening to reason, listening to voices around them, and then making kind of an informed decision. And sometimes their protective inhibitions go away. So that's an example of, after the age of 60, whether you're the CEO of a company, whether you're a surgeon, whether you're the president of the United States, we need to be careful about their critical decision making and the assessment of it.
Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you the hottest and most crucial conversations in healthcare and physician leadership today. As promised, this month's shows are all about emergency readiness and response, especially in light of events in the Middle East right now. And we have another exclusive guest who knows quite a bit about that, Dr. Jeffrey Kuhlman. Having earned his medical degree from Loma Linda University and later becoming triple board certified in aerospace, family, and occupational medicine, for the next 30 years, Dr. Kuhlman served as a Navy physician, and for more than half of that time, he served in the White House. Responsible for emergency medical actions and contingency planning of the White House Medical Unit and integrated with the Secret Service details, Dr. Kuhlman was the physician on the White House grounds on 9/11 and spent the day in the Presidential Emergency Operations Center, also known as the bunker, providing guidance and advice on all joint service, interagency, and international matters for medical contingency planning and operations, supporting the continuity of the presidency and an enduring constitutional government. In 2007, he was named the director of the White House Medical Unit, and in 2009, Dr. Kuhlman served as the physician to the 44th President, Barack Obama. Over the course of his time as a physician in the White House Medical Unit, he also cared for President Bill Clinton, President George H.W. Bush, Secretary of State Hillary Rodham Clinton, and Vice President Joe Biden. Following his time at the White House, Jeffrey moved to my backyard, where he became the Senior Vice President and Chief Medical Officer at the largest hospital in the United States, the formerly named Florida Hospital, now known as Advent Health Orlando. The author of several books on transformation in healthcare and high reliability, not to mention his recently published call to action book entitled Transforming Presidential Healthcare. Currently, Dr. Kuhlman is the Chief Quality and Safety Officer for the Advent Health System. Jeffrey, welcome to the show.
Good to be with you. Interesting hearing it put in that context, but just was privileged to serve all those people, and I call it 5.5 presidents.
Well framed. Well, early in your career, you were a flight surgeon. You had a duty to the Navy to determine someone's fitness for service. So since you mentioned that you've served multiple presidents throughout your career, if you deemed someone physically fit and mentally strong as a flight surgeon, were there additional criteria that you would use to limit flight actions, such as their age, and who ultimately determines those criteria and how you sign off on them?
So with naval aviation, it covers all pilots, all aircrew, both in the Navy and in the Marine Corps. The Naval Aerospace Medical Institute actually puts out and keeps up to date, pages and pages of physical standards, and then you are either found fit for duty or you can be found not fit for duty. And if somebody is deemed that they don't meet all the requirements, physical requirements, then it gives you a guidance about how to put in a waiver. For example, if they have, thyroid disease and they're taking thyroid medication, that disqualifies you from aviation. But if you meet the requirements of here's the medication, here's the stability, here's the dosing that you're taking, and you don't have any other side effects, everything else is normal, then you put in for a waiver and that aviator can be granted the waiver. So it's extremely helpful to have a guide saying black and white, here's the qualifications and here's how you do waivers in a standard, fair way.
In the Navy, is this coordinated by other more senior flight surgeons and medical personnel, both the criteria, for example, using the thyroid example, and therefore then the waiver, or does the individual flight surgeon create those specific criteria?
The individual flight surgeon at the squadron taking care of that aviator is responsible to do the exam, do the test, to be familiar with the waiver guide and to follow the waiver guide. On that submission, there is a panel of experienced flight surgeons, and they also bring in a different subspecialist. For example, thyroid would be an endocrinologist. And most of the time, it's not a new waiver. It's something that's been done before. And your job is to be the advocate for that aviator to make sure that you're addressing what it says in the book.
And then if we pivot to the civilian side, are there are there similar parallels relative to the FAA in the sense that whoever is performing the flight physical also has criteria by which they can or cannot fly, waivers by which they can be granted or not granted, and who ultimately determines all of those criteria?
Yes. So for the civilian world, any flight surgeons are aviation medical examiners, which means we pass the testing, the designation by the FAA. The FAA puts out guidance of, is it a class 1, class 2, or class 3? It depends on if you're, flying a 747 full of 300 people, or if you're just going by yourself in a single engine prop. The aviation medical examiner does the physical and is responsible to follow the guidelines that are published and updated by the FAA. Everything is done above board. You submit that to the through the FAA route.
So thank you. So the listeners by now are probably wondering, why did we jump from your incredible experience at the White House into the dynamics of flight physicals, both on the Navy and in the civilian realm? And the reason, and you and I talked about this, is because I'm fascinated by the lack of parallel that we see amongst our hospital colleagues, you and I being both of those, and how we apply those criteria to the medical staff. And you and I talked a little bit about this. I wonder if you would share your thoughts on why doesn't the generic house of medicine writ large have such a dedicated set of protocols for our physicians relative to their fitness to practice? And what have you done in your career relative to that?
So as a chief medical officer, it has something to do with physicians, the medical staff, APPs, and the 4 biggest areas are performance, patient safety, professionalism, and persuasion. The medical staff is responsible for the quality and safety at the hospital. Most medical staffs have a physician health advisory council, and there's varied levels of how high functioning and how well they perform. Most hospitals do not have guidance based on age, and they don't have guidance based on medical conditions that are disqualifying. Unfortunately, we rely upon somebody bringing up, hey, this surgeon, they have a tremor that's pretty noticeable, and I wonder if they're safe in the operating room. A big part of the Physician Health Advisory Council has to do with substance abuse, mental health, and those are usually episodic things that flare up. There are a few hospitals in the US that are trying to be more proactive and, for lack of a better term, call it the aged or aging surgeon. That I've seen 95-year-old surgeons that are outstanding in their skills, in their judgment. I've also seen 60-year-old surgeons that had memory problems, had decision-making problems, and would kind of fumble through some of their steps to do a procedure that they've maybe done 1,000 times in their life. I think as a chief medical officer, being aware of, can the physician do the critical decision-making that they need to? And can they do the physical skills of the procedure that they're doing? And I think that is, a fiduciary duty for chief medical officers to help the medical staff make informed decisions.
That is a very insightful statement about the fiduciary responsibility of the chief medical officer. And we're going to come back to that in just a moment. I agree with you that elements of a tremor, a gait disturbance, ataxia. These are often very visible to the peers in the department and the members of the operating room team and staff. And those can be evaluated and decisions rationalized around that. Substance abuse sometimes is often very difficult to detect. And fortunately, most state medical boards and licensing programs offer different pathways for people to recover because it is an illness that can be treated and people can improve just like any number of medical conditions. You mentioned a little bit about somebody's memory. So we'll talk about the realm of cognition. And that can be a very subtle area where it can be very difficult to detect that somebody is showing cognitive decline because with years and years of experience, muscle memory takes over, the order sets become familiar and protocolized. So you mentioned the 95-year-old surgeon who is physically excellent at his or her skills in the operating room, but yet you could have a 75 or an 80-year-old individual showing cognitive impairment. Have you had to deal with that as a chief medical officer or as a safety and quality officer, where it became really personally challenging or difficult for you to tell a physician that an assessment needed to be performed?
I think when you have a large medical staff, every month there's an issue. The medical staff that I was part of, there were 3,000 physicians on the medical staff. So there's, even if it's 1%, that's 30 individuals that you're dealing with. It's popular in America to say, age is just a number. That's okay as a meme or as a slogan, but when you're talking about a surgeon or a physician who's making critical life-saving decisions or actions, age is not just a number. The big three physical conditions that I think of where age is by far the biggest risk factor are the big three: cancer, cardiovascular, and then neuroprogressive disease. So that's where age becomes extremely important. If we go to the neurocognitive assessment, once you get past the age of 60, it's a fact of science that humans in the 21st century, memory, reasoning, speed of processing, spatial visualization all start to decline at an accelerated process. The fifth one of those, vocabulary, is odd. It tends to stay the same, or it tends to creep up a little bit based on a lifetime of using and knowing words. So when you say, grandpa or that 80-year-old surgeon, they're being more stubborn, it's not just a personality trait. It's they're declining of listening to reason, listening to voices around them, and then making kind of an informed decision. And sometimes their protective inhibitions go away. So that's an example of, after the age of 60, whether you're the CEO of a company, whether you're a surgeon, whether you're the president of the United States, we need to be careful about their critical decision making and the assessment of it.
Yes, agreed. And you point out that with a large medical staff, there's always something that comes up. And I am very confident that you have had to face these issues repeatedly, and I did too. And they're challenging every single time, but you hinted at it, and we're going to keep pushing further along about the responsibility of the medical officer, which is why I started with your time as a flight surgeon. And what I was trying to draw out is this training, this principle, this repetitive responsibility that a medical officer, flight surgeon, et cetera, has relative to the safety of others. And that, an independent practitioner, if they're the sole person in a rural town, they may not have somebody over their back, but in larger and larger systems and organizations, there are certain responsible agents, such as the roles that you've had. So now I want to talk about the time in the White House Medical Unit where you served as both director and physician directly to the 44th president. So please explain to the audience, what exactly is the White House Medical Unit? For what purpose does it exist, and the responsibility of the director?
Well, luckily, I wrote the book, Transforming Presidential Healthcare, that is 300 pages packed full of that information. My short answer would be, when the original GW, when George Washington became president in 1783. The military person that he had accompany him to be president, which was up in New York, not in Washington, was his regimental surgeon. So Colonel James Craik. So the physician to the president, or somebody acting as a physician for the president, has been around since, the dawn of our government, of our country. It didn't become a full-time job until, unfortunately, after President McKinley was shot and died in Buffalo, New York. The physician at the time, Presley Rixey, was a Navy admiral, was taking care of Mrs. McKinley, who was an invalid. She had a long history of seizure disorder. And so he wasn't close proximity to McKinley. And McKinley, had a couple gunshots to his thorax, to his abdomen, but he probably died of sepsis from all the probing that had been done at that time. So after that, Teddy Roosevelt, when he became president, that's when it started being called the White House. Before that, it was the Executive Mansion, said, I want you to be a physician in the White House full time. So that's kind of the dawn of a physician. 1927, the Congress codified the office of attending physician to Congress. And they said, well, if we get one, the president gets one too. And so that's when they codified a job called physician to the White House, which was basically the lead White House physician for the president. And then in 1945, helping the physicians taking care of the president, the White House Medical Unit was organized. And since that time, the White House Medical Unit, the vast majority are active duty Army, Navy, Air Force, Coast Guard, doctors, nurses, airmen, medics, healthcare administrators, physical therapists, whatever's needed. And they are a loose coalition that technically belong to their respective branches, but they all work together on the 18 acres, which is the White House complex. And anywhere in the world, the president or the executive branches, there's members of the White House Medical Unit taking care of the president, the vice president, their families, and others, both in classified and unclassified missions.
So right now, as we're speaking, there's a tremendous amount of hostility in the Middle East, and reports have come in this morning, not surprising, and certainly not to someone like you who has served close to the president and the White House, that there are risk assessments on members of our government at the highest level. There is something you mentioned to me called the tactical medical officer. Would you elaborate for our listeners the role of the tactical medical officer, and perhaps framed in the moment, not of a pneumonia or some other physical ailment, but a critical event, if you will?
Yeah. So unfortunately, in our history, we've had 4 presidents that have been assassinated while in office. I think as medical professionals, if we look back at Lincoln and Kennedy, there is nothing that modern medicine could have done to save them. They had direct wounds to their brain that I think would even be fatal today. McKinley and Garfield, I believe, and others believe, that they would have survived if we'd had 21st century care, 100, 150 years ago. I was a teenager in Chattanooga, Tennessee, driving to my lift truck job at Little Debbie, and I heard March 30 of 1981 shots fired at President Reagan while he was at the Hilton there in D.C. We later learned that he had been hit, and his special agent in charge, Jerry Parr, was on top of him, saw a drop of blood in his corner of his mouth. And at the time, the practice was shots fired, take him back to the fortress, take him back to Crown, which is the Secret Service code name for the White House. Special agent in charge Parr said, forget this, we're going to the hospital. So they went right instead of left, and they ended up at GW Hospital. What saved him is when he walked into the emergency department and collapsed, the doctors and nurses in the emergency department treated him like a trauma. They treated him like a trauma patient. They did not treat him like a VIP. So with that, they took him to the operating room, and they had recent training and experience, whether it's in support of Vietnam War at the time, but they used the greatest techniques. Fast forward about 20 years, during President Reagan, during President George H.W. Bush, the physicians that were the physician to the president were, let's just say, elderly specialists, and they were not trauma focused or trained. About the year 2000, maybe a year or two before, the White House Medical Unit started hiring emergency medicine physicians. When I got there, there were a couple outstanding emergency medicine physicians. The training was individualized instead of standardized. So we got together as a unit and we said, what's our mission? Our mission is, to keep the president alive. Number one threat is sudden cardiac arrest. So we're going to have an AED, and we're going to be within 2 minutes, and we're going to be current on our ACLS training with current clinical competence. And so that's kind of the number one threat. Number two threat is a gunshot wound or knife stabbing. What is the appropriate care? So, it is not call 911. It is, the shortcut would be care under fire is the term that I like to use. And so with that, a few years later, there was Afghanistan, Iraq. And so the doctors, the nurses, the PAs were coming, the medics, they were coming back with battlefield experience from the greatest survival rate in combat. And so that's where tactical combat casualty care and basically care under fire is, if the principal, the protectee, if they get hit once, keep them from getting hit again. Prevention is always better than the cure. If somebody is hit by a gunshot wound, you don't worry about C-spine. You don't worry about fluids. What you worry about is keep the blood in the body and get them to definitive care. So however you want to stop the bleeding, hemostatic bandages, dressings, tourniquets. You got to have the equipment. You got to be trained. You got to have current clinical competence, and then move to a transport vehicle, whether it's a helicopter, whether it's a armored Suburban, an armored limousine, an ambulance, whether it's a white ambulance or a black ambulance, whatever you have available, and you get them to not the closest hospital, not the closest ED, not to a doctor's office. You get them to a level 1 trauma center as soon as possible, and let them treat them like they do every day at the Knife and Gun Club. The tactical medical officer was our probably about 2005. Our junior physicians or our experienced PAs, when they came in, they had a specialized backpack. So think special forces medic capabilities. And they have enhanced ways to keep the blood in the body. And then the third thing is there's also asymmetrical threats. So chemical biologic attacks. We've had, there's been anthrax. There's been talks about smallpox, tularemia, plague, viral hemorrhagic fever. Those are the big five according to the CDC. So make sure that we're trained in the medical effects of biological and chemical warfare. So kind of know the monitoring, know the treatments. And so the tactical medical officer also is part of that decontamination, evaluation, treatment. And the third thing they do is they advance every site that the president is going to go to. And we have a plan. The doctor and nurse, we're kind of busy if there's a medical situation going on, but the Secret Service are wonderful to work with, and they will get us to the designated facility that we're going to. And so that's how we practice and that's how we play.
Fascinating look inside a small area of our country that most of us are never going to be in a position to know until you've shared it and what you've also written in your book. But I would encourage our aspiring physician leaders that live and work in hospital environments to think through the threats that can occur at their own institution, independent of a government official, and how to run the right scenarios and have the right tactical answers to not just a mass casualty event, which we've seen far too many in our lifetime, but simultaneous attacks. And we saw a lot of this during COVID, the threats of civil unrest, the threats from non-state actors. You and I were both getting those messages, I'm sure you were, through our emergency management team while we were managing so many other things. And it's important to have the right tactical responses and to be prepared. Our emergency room physicians go through the training and they know the SALT and the START triage principles, who you can quote save and who you cannot, and how to manage the immediacy of stopping the bleeding. And you don't have the luxury of open IV fluids, open wide, start 2 IVs like you're taught in medical school. These are very serious events that require serious training.
Yeah, maybe just a couple things that we did pre-hospital. So the emergency medicine physician, they're king in the ED with their equipment, their team. But, out on the field, we're all the same. Everyone's equal. So it's your experience, your equipment, and the procedures you go through. So things that we did is whole blood. So they're even just now, they're arguing about whole blood. So whole blood saves lives, especially when you are shot and you're losing your blood. And then also TXA. So we gave, the academics still argue about TXA, but the immediate bolus of TXA, if you don't have it, then you can't use it. So we made sure that 20 years ago, we had TXA, we had a plan for whole blood. We took it with us, and, it was the code name makeup. So we don't want to yell across, hey, did you get the makeup out of Air Force One and put it into the follow-up? We would say makeup. We don't want to say, did you get the president's blood? So that was our code sign, and we carried that all over the world, except when we went to Iraq or Afghanistan, because we have the world's best walking blood bank with our soldiers and sailors and our airmen that are stationed there.
So let's stay on that a little bit. I know that at our institution, when I was the chief medical officer, I worked very closely with the trauma team, and we instituted whole blood, and we put it available to our life flight, our helicopter or air transport team, and has a significant impact. And you've mentioned a lot of this was learned in combat and applying that. And of course, the White House Medical Unit far in advance of most community facilities in understanding this. But let's come back to emergencies involving members of the White House, particularly the president, and both standards and fiduciary responsibilities. As an example, President Trump received the Regeneron monoclonal antibody product, not yet approved by the FDA, at the time that he was diagnosed and hospitalized for COVID, and he received it under the compassionate use rules that most of our physician colleagues know what that is. Do you hold an opinion if different standards also should apply for those under the White House Medical Unit care and the responsibility of that team for routine medical care as well as preventative care, and how to apply an appropriate standard, as you've discussed, in an acute penetrating injury like a gunshot wound, to a president who is suffering pneumonia with a novel disease with not yet fully approved therapy and other types of events? How do we apply the right standard for the situation at hand?
Yeah, so that's probably a complex, multi-dimensional question. When you're taking care of the president or you're taking care of anyone else that's sort of in that VIP category, what I would say is do not take any shortcuts. The essence of my job as the director of the White House Medical Unit was getting every primary care doctor who's caring for the president or one of their family members to do everything that you know how to do, that you're trained how to do. Because often in VIP care, the primary care doctor, well, I'm not going to check for glaucoma in this patient's eye because the ophthalmologist is going to. So do not take any shortcuts. The primary care doctor, do everything that you're trained to do for the evaluation of that condition, which should cover about 95% of things. And healthcare is relationships built on trust. And a lot of being the White House physician is being the quarterback and making sure that the primary care doctors do everything they're trained, and then, helping the specialist laser focus onto what's really needed. As far as President Trump's COVID, I'm glad that he got Regeneron monoclonal antibodies. I gave it to several patients that met the indication. The other thing is he met the criteria for remdesivir, and they gave it to him inpatient at Walter Reed. And so the doctor's taking care of him. I think if you listen to any of their reports, Dr. Conley said, I wanted to give the country upbeat, positive messages. And luckily we had the chief of staff that was more medically truthful than the doctor. I would just encourage any doctors, when you're when you're giving public reporting, don't do disillusion, deception. Just tell the truth. Just be factual, tell the truth. And President Obama told me, never lie to the American people. Eventually, they'll find out the truth. And so I think that's always good guidance.
Yes. In the Chief Medical Officer Academy, by which I teach, we have a whole segment on situational media, and we compare and contrast how a chief medical officer can stand in front of the press and give deliberate and truthful, but not necessarily all of it all of the time, but always truthful and direct as they would to a patient, and not to be deceptive or hide facts or provide misinformation to people. So agree with you on
And
that.
I think that's the fiduciary duty and the moral obligation, whether you're a chief medical officer, whether you're a physician taking care of patients, or whether you're the physician to the president.
Agreed. And that may create some internal and inherent conflict amongst physician leaders, particularly when they work in organizational structures that may have a business model, for example, that places that physician leader in conflict with their principles or their oaths that they take upon graduation and the licensure that they apply for, to uphold certain standards by the community of physicians, by the house of medicine, if you will. And it's often distilled to the notion to do no harm, because there are potential harmful events that occur with over-treatment and over-testing. And so physicians are trained to develop that balance and nuance. And as officers of companies and of medical organizations or in service to the country, we have to balance that. And sometimes that creates a lot of internal conflict. And I don't know if there are any examples that you want to speak to for our listeners about how to navigate the fiduciary responsibility as a physician to the president or the chief medical officer responsible to the organization and to the patients that they serve.
So if I think about history right now, we're using the president as an example. So James Madison, I think, was the lead author of the Constitution. When he submitted his final draft of the Constitution, September 17, 1987, he was 36 years old. At the time, a 20-year-old male in the colonies, in the newborn United States of America, might live to age 60 if they're lucky. George Washington, he finished his second term in office at age 65, and he died 2 years later. One of the challenges we have is there are not physical requirements to be president of the United States. If you look at the Constitution, you have to be 35 years old. You have to be a natural born American citizen. We know that's not true. The first 6 presidents weren't. They were born British subjects. And, who knows if John McCain, he was born in Panama when his dad was stationed there. We do know President Obama was born in the state of Hawaii in 1961. It had been a state for 2 years. So the third requirement is you have to live in the U.S. for like 14 years, be a resident. So there's nothing about the physical qualifications. There's nothing about the mental qualifications. So most presidents in history have had physical impairments. They've had a shoulder that doesn't work, orthopedic. Some weren't able to walk or ambulate. Others were deaf, or others had poor vision. Some had suffered strokes, and many, had cancer. So all that's part of history. If we can accommodate for those impairments, we can pretty much do that reasonably for most everything except for critical decision making. So critical decision making, I'm at least on the record with, New York Times asked me to submit a essay about a year ago. It was published in the New York Times a few hours before President Biden dropped out of the race. So with that, I believe that over the age of 70, you should have some type of neurocognitive assessment. Not a 1-minute MOCA screening test, but you should have some neurocognitive assessment that checks your memory, reasoning, speed of processing, your spatial visualization, and your vocabulary. And it shouldn't just be the president or the candidate. It should also be, we have Supreme Court justices that are, well over the age of 70. We have 20% of our 20% of our senators are over the age of 70. We have them that are 91 years old. Strom Thurmond was 100, and still in office. And it's just a well-known fact that he had profound dementia. And it's a bipartisan issue. Robert Byrd also, was well past his 90s. And Dianne Feinstein, she had a herpes encephalitis, but stayed in office for many months. So I think that we need to be neurocognitive assessment of elderly physicians, skills assessment of surgeons, and then also, if you're the leader of the free world, age is not just a number.
I have to process this for just a moment because that was a little bit of a master class in fiduciary responsibilities. And what I mean by that is, and I started the questions around how we help our young physician leaders think about their internal obligations to practice the best medicine that they are skilled in, trained in, certified in, etc., but that they have obligations in leadership that become obligatory to the structure and the system in which they work, like FAA flight physicals, a Navy surgeon, the White House medical unit. And you have to be able to hold both simultaneously to not only direct the care of the patient in front of you, but what's safe for the passengers on the plane, for the leadership of our country, and to think through delicately, like you're talking about, critical decision making. You would not be fulfilling your fiduciary role if you didn't ask that question. How do we assess critical decision making? What are the criteria? Can we as physicians allow people to function in a way that they may not have their full capacity, and the impact is extraordinary? And so I know that there's a lot of discussion these days around moral injury, and that organizations make decisions that cause a sense of harm to practicing physicians, that they've lost their autonomy, that decisions are taken away from them. And in this framing of moral injury, it implies that more physicians ought to be in roles of decision making for organizational health and well-being and the practitioners. And that also we need to be cautious about whether organizational non-physician leaders should take some form of oath. I believe it was Don Berwick, the former administrator of CMS and the founder of the IHI, who testified before Congress that perhaps non-clinical CEOs and leaders of healthcare systems ought to also take some oath relative to the care of patients, like the Hippocratic Oath. You have any thoughts on whether people in those positions should take some type of oath relative to their organizations?
Well, when I think about public safety professionals, I think of police officers, I think of pilots, I think of physicians, and I think of presidents. And so for all of those professions, there has to be protections that we give the public for their safety of this individual can do their job. They are physically and mentally at the top of their game. We don't want a pilot that can do his job 95% of the time. It's got to be 100% of the time. Error-free operations in a complex situation is high reliability. For executives, we see the silent generation. We see the baby boomer generation, that they are clinging to power more than any generation has. I think Warren Buffett at 93 just realized that it's probably time to have a succession plan. And, he has a job of responsibility and a fiduciary duty to all of his Berkshire Hathaway stockholders. If you're the chief executive of a hospital or a healthcare system, if there was some type of a commitment to patient care, patient safety, that would be awesome. We're going to quickly go down the road of, usually that's what the not-for-profit systems are for the benefit of the community. If you are in the for-profit category, then they have a responsibility to help their stockholders. So that is often the care that you get at a for-profit institution versus a not-for-profit. Often you can feel the difference.
Thank you for that answer. This has been a spectacular show and learning a lot of things I never ever considered, but quite applicable to hopefully our listeners who are growing into their healthcare leadership roles and responsibilities. Jeffrey Kuhlman, the author of Transforming Presidential Healthcare, among other books on safety and reliability in healthcare. Maybe you and I should write transforming the United States healthcare system relative to oaths and obligations of all of its leaders. Because whether you're in a for-profit, not-for-profit, or independent practice, there is a public health responsibility, and we saw that in COVID. COVID did not know party, race, gender. It affected every part of our society, and both the for-profit and not-for-profit systems had to bear the brunt for public health, safety, and well-being. Any last words before I wrap it up to our listeners? Any words of wisdom you want to share?
Yeah, I think you're on to something about, we see an administration that is dismantling public health in the U.S. It's kind of been dismantled over the past generation or two, but we have an opportunity for public health in the emergency department. In the emergency department, it's the safety net, the biggest access for anyone that finds themselves in America. We are already doing it today, public health. They evaluate respiratory illnesses, sexually transmitted infections. They evaluate foodborne illness. They administer vaccination against pertussis or against tetanus. And so those are just already in place. We have some hospital emergency departments that are doing the opt-out HIV screening, where every single person that's getting their blood drawn, you screen them for HIV, you remove that stigma, and we're actually finding individuals because half of the new cases, they don't know that risk, and we connect them to like the Ryan White Clinic where they get life-saving treatment. Same thing with hepatitis C. We have cures. You got to screen, you got to connect them to care. People that are at high risk, give them hepatitis A and B vaccine. It's one shot. Substance use, we have new medicines, either shot or sublingual, and connect them to care. So I think this is different than chronic disease management in the ED. This is different than the social drivers of health, which those two things are important. But I think we should be preaching public health in the emergency department, and it will save thousands of lives.
Agreed. Well, thank you again, Jeff. For our listeners, you have been front and center to hearing some great history and some insight as to how things operate in a place you may never get a chance to see for yourself on the only podcast dedicated to the Chief Medical Officer of the Fire Chief Podcast. If you want access to the latest and greatest hot items for physician leadership, particularly if you want to become a chief medical officer, visit our website, thefirechiefcmo.com, and sign up with us. You can leave your comments about the show, tell me what the next hot mess in healthcare is all about, and what physician leaders should be doing about it. I truly love talking with physician leaders, chief medical officers, and other high-ranking officials from all over the United States. So please connect, leave your reviews, leave your comments, and share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.